Okay, so this particular session is on optic nerve, right? Optic nerve. So we are going to quickly look at the optic nerve and what lesions on different parts of the optic nerve presents, right? So the optic pathway, first of all, optic nerve is cranial nerve 2, okay? And the optic pathway essentially tells you what happens to the optic nerve from the point of um, from the point of impulses from the retina, all right, down to the brain, all right, down to the optic, down to the visual cortex. I mean, okay, from the retina down to the visual cortex. And if any part of this pathway doesn't work right, whether it is the optic nerve, whether it is the retina, whether it is the visual cortex, you know, whether it is the optic radiation, whether it's at the chiasma, any lesion on any part of this optic tract will prevent a person from seeing clear images, all right? And from the presentation, one will be able to decipher what type of optic nerve lesion we are talking about. So, for example, let's trace it first of all. There's the retina. Let me show you what it looks like. All right, so this is the eyeball. A person, your own, also looks like this. Okay, then this is the retina at this point. All right, then just below it, you have the optic nerve. Sorry for interrupting the live stream. All right, so just below the optic nerve, just below the retina, the nerve, what you are seeing here is the optic nerve, all right, which moves along till it gets to a point like X, an X-shaped point that is referred to as the optic chiasma. All right. So beyond the optic chiasma, why it is called a chiasm is that there are some crossing of fibers at that region. So it's X-shaped because there is crossing of fibers at that region. And beyond the optic chiasma, you have the optic tract. Okay, the optic tract. So this is the optic tract, right? Then after the optic tract, all right, impulses move from the optic tract to what is known as optic radiation. All right, some impulses go to a place known as lateral geniculate body. Okay, then from that lateral geniculate body, some impulses move to the superior colliculus to modify the vision. And there's also a relationship between the lateral geniculate body and a place known as the Edinburgh spiral nucleus in the in the midbrain, all right, which has relationship with the third nerve, which is oculomotor. Okay, and that's how you have these light reflexes. Okay, remember that optic nerve is sensory, while oculomotor is motor. Okay, so that's how light reflex, both direct and consensual light reflexes, is carried out, that reflex. Okay, so From that geniculate body, superior colliculus, all right, impulses flow via a place known as the optic radiation. Okay, impulses flow down, and you know that the optic radiation will pass through both the temporal lobe and the parietal lobe. Okay, before eventually it gets to the place known as the calcarine sulcus, right, which is the part of the occipital lobe where you have the visual cortex. Okay, so a lesion in any of these parts of the pathway will give you different symptoms. So if you have a lesion on the retina, right, you expect blindness on that side of the eye. Okay, blindness on one side of the eye. You have a lesion on the optic tract, you're expecting blindness on that side of the eye. Okay, on that side of the lesion, on the that side of the lesion, all right? Then you have this like total blindness, total visual loss. You can see here. So these circles here represent what the person sees, like what the person with this lesion sees. So a person with lesion at the optic tract or at the level of the retina will see something like this. This is blindness, total. Everything is black on the affected eye. All right, you can see it's total blindness. All right, while the other eye is good. Now, a lesion at the optic chiasma gives you something known as the bitemporal hemianopia, right? Bitemporal hemianopia. Bitemporal because it affects the two temples, right? You know, the eye, the visual field is divided into the temporal region and the nasal region, all right? So bitemporal means it affects the two lateral sides of the eyes, both eyes. And the reason is because as impulses flow through from the retina through the optic tract, as it gets to the optic chiasma, it divides into two. The medial side of the impulse, which inadvertently carries impulses from the lateral side of the temporal part of the eye, because you know the visual field, it kind of reverses, all right? They cross at the lens. This image did not show it, but images cross at the level of the lens. They reverse. Okay, so these fibers on the medial side here actually carry impulses from the lateral side, which is the temporal side of the eye, temporal side of the face. Okay, so these impulses will get to the optic chiasma and cross over to the other side. Same thing happens on the other side too. Whereas the impulses that are coming from that are on the lateral side, coming carried by the nerve on the lateral side, which are inadvertently impulses from the medial side of the face, the nasal side of the face, all right, will remain on the same side. So when there is a lesion on the optic chiasma, for example, lesions like this perennial pharyngioma, celatosaica masses, okay, like pituitary gland adenoma, all right, whether it's microadenoma or macroadenoma, or lesions, cranial pharyngioma, you know, things that grow around that region will affect vision bitemporally. Okay, so you have a bitemporal hemianopia. Now, by way of introduction, remember that anopia means blindness. So hemianopia, half, bitemporal, temples are affected. So that's the breakdown of that lesion. Now, if you have a lesion on the optic tract, what do you think will happen? You have impulses. Let's trace the pathway. Okay, impulses from this side, and there's a crossover from the other side. Okay, remember this blue is carrying impulses from this side, while this red is carrying impulses also from this side. Okay, so you now have a homonymous hemianopia. Okay, contralateral homonymous hemianopia. So it is opposite to the side of the lesion. That's why it's called a contralateral homonymous hemianopia. You can see it. It's very clear. Let's trace the red fibers. The red fibers here. They're actually carrying impulses from the nasal side space. Now, let's trace the blue fibers. They crossed at the level of optic chiasma, and they are here at the nasal side. They're actually carrying impulses from the lateral side of this eye, temporal side. So it means essentially that all the impulses, the kind of blindness this person will see are lesions on this side and lesions on this side. So they are on the same side. That's why they are called homonym, all right? Homonymous, but they are contralateral. To give contralateral homonymous hemianopia, right? As you can see here. Okay. So if you can draw these images in your brain, if you can draw these images in your brain, in your head, and have it at the back of your mind all the time, then whenever you see questions relating to the visual pathway, you will just be able to pick the answer with the snap of a finger. All right. So let's look at what happens when you have a lesion at the level of this. Okay. So this level is the level of the parietal lobe, while the lower one is at the level of the temporal lobe. So something called the ST segment. All right. ST segment. That's the code. That's the mnemonic. All right. You can use to remember how this thing works. Okay. So what you have, whether it's a lesion of the temporal lobe, what you have is a quadrantanopia, all right? Just a quadrant. And a quadrant is half of a quarter of a circle, right? The whole visual field is like a circle. Divide it into two, it becomes hemianopia. Divide that other half into another half, that's 1/4. It becomes a quadrantanopia, all right? So when you have a lesion in the parietal lobe, okay, you will have an inferior quadrantanopia. Contralateral homonymous inferior quadrantanopia. That's the full name of the lesion. You can see it here. Okay. Contralateral inferior homonymous quadrantanopia. Then when you have a lesion on the temporal lobe, remember I told you that the code for it, the mnemonic for it is ST segment. So ST, that ST there is superior quadrantanopia for temporal lobe. Then once you get that, then it's easy to infer that inferior quadrantanopia will belong to the parietal lobe. And these are strong MCQ questions, and you will see them in the exam. And this is at the level of the optic radiation, because the optic radiation passes through both the parietal lobe and the temporal lobe. And the lateral aspect belongs to the temporal, and while the medial aspect belongs to the parietal lobe. Right? So eventually, impulses get to the visual cortex. Okay? The place known as the calcarine sulcus. Right? So a lesion of occipital visual cortex will cause a contralateral homonymous hemianopia with macular sparing. This is how you differentiate. This macular sparing is very important because that's what tells you that this lesion is at the level of the visual cortex, right? That macular sparing, okay, that's what gives it away. And when it's bilateral, you now have what is known as a cortical blindness, all right? When it's bilateral, when it is unilateral, the other eye can still try to make up for it because after all, the person is having a contralateral homonymous hemianopia with macular sparing, all right? So that's how you differentiate this particular lesion from the lesion at the optic tract. They are almost the same thing. The only thing that differentiates them is the macular sparing, okay? So with that, I think we have done justice to the visual cortex. Let's look at the lesion will cause scotoma. Scotoma is a small area in the patient's visual field where he or she cannot see. A lesion on the retina will cause scotoma. Okay, just a small area on the patient's visual field where he or she cannot see. A lesion on the optic nerve will cause common cause is multiple sclerosis, which causes optic neuritis. Yes, some form of multiple sclerosis forming neuritis. For example, neuromuscular, whatever. Okay, NMO. Neuromyelitis optica. Neuromyelitis optica, where it affects, you have this optic neuritis, and then you have neuritis, that's generalized neuritis. So it's a type of multiple sclerosis. Okay, so that affects the optic nerve, causes sudden loss of vision in one eye, and there's usually dull pain when moving the eye, cause monoocular blindness. Remember that whatever affects the optic nerve just darken that entire eye. All right. So lesion on the optic chiasma, like I mentioned, is things like craniopharyngioma, macro pituitary macroadenoma, then meningioma as well. Then visual field loss is bitemporal hemianopia. Then lesion on the optic tract, like I mentioned, is very similar to the lesion on the brain itself. So you have a contralateral homonymous hemianopia. Okay. So non-congruous homonymous hemianopia. All right. So common causes include a stroke, cause, cause stroke, and tumor are the common causes. Cause a homonymous, remember I told you it's quadrantenopia, but you now want to know plural. Effect is always on the opposite side to where the lesion is. Like I mentioned, it's a contralateral homonymous, all right? Bilateral lobe lesion will cause a cortical blindness, like I mentioned earlier. So when it's bilateral, it causes something known as the cortical blindness. Okay, so that cortical blindness means that this patient feels that he can see, but in actual sense he cannot see. So the patient denies that he's blind, but all evidence points to the fact that he's blind because he holds objects, he does not recognize faces. He claims that if you ask him, can you see? Can you see me? You say yes, that he can see you. But he can't see you. Maybe because he'll be looking at somewhere else and saying, yeah, you can see. So the next time we'll be discussing how we've done justice to the optic nerve.